Thank you for letting me talk today. I had nothing to close. So what we found is that in about 40% of women with refractory Detrusor overactivity, that they all have recurrent urinary tract infections. And what we found clinically is, like our previous speaker just said, as soon as you treat one with antibiotics, you test the urine again and it's a different organism that's then present in their urine. These patients start to develop antibiotic resistance, and this makes their treatment even more difficult to treat. So therefore, we wanted to investigate women with refractory Detrusor overactivity and coexistent recurrent urinary tract infections, and it was about over a 24-month period. We collected midstream urine samples after careful labial toilet. Half of the urine sample went for routine microbiology, and we noted the culture reports. The other half went for culture-independent 16S ribosomal RNA sequencing, very similar to Linda Brubaker's technique. And then we wanted to determine the changes in bacterial composition in the urine of these women over time. We recruited 9 women with refractory Detrusor overactivity, and overall we had 42 urine samples. They were all postmenopausal, all on topical estrogen. All those that had a voiding dysfunction were managed with double voiding, and all had a cystoscopy to exclude cancer, but they all had cystitis cystica, as you can see in this picture down here. So while this is a really busy slide, what this shows is we've got the patients down this column here, and each line represents a different urine sample. And across this axis is the actual bacteria that was sequenced by the 16S ribosomal phylogenetic group. So of the routine microbiology, only 4 of these samples had no growth, 18 samples had a reported organism, of which 13 were E. coli, as you can see in this column. And what I haven't mentioned, is that the Y represents what the organism was that was reported by the lab, and the deeper the colour, the higher the proportion of the bacteria in the sample as detected by the RNA sequencing. What was also, 17 urine results also had mixed growth, and of these women, only 2 didn't have any antibiotic resistance. If we look at patient number 5 a little bit closer, she had 15 confirmed urinary tract infections in 24 months, and she had grown multiple bacteria over this time. Her E. coli that she grew on numerous samples was resistant to trimethoprim and amoxicillin. And what you can see here is that this sample here was quite interesting because that was an Enterobacter, and that was what was pretty much the predominant organism in that sample. The ones where she was treated with antibiotics is represented by the star, and as you can see, there's quite a few of the A group, as Linda Brubaker called them yesterday, that are very difficult and fastidious to grow in the lab, but can be uropathogens. And what this clearly shows also is that the organisms in these urine samples did change over time. So what we can show is that the microbiome definitely does change in women with refractory Detrusor overactivity, and the routine microbiology only reports the dominant organism. And now or mixed culture. Now these mixed cultures may actually be important clinically because if you treat just the predominant organism, there's a whole lot of other organisms there that you're not treating. We're therefore maybe encouraging their growth and encouraging the antibiotic resistance. And this may also help us understand why these women with refractory Detrusor overactivity don't respond to anticholinergic medications due to the fact that they've got these constantly evolving urinary tract infections. Thank you.
So, questions from the floor?
Okay, thank you for the nice presentation. My question is, have you tested what's the E. coli strains? How many of them? What's the major strain in these patients?
We're actually undertaking FIMH sequencing of the E. coli strains at the moment. So I don't have that data yet, but it's in the pipeline that we would be able to determine whether or not it's the same strain that's reinfecting the bladder or whether or not it's a different strain of E. coli that's causing the problems.
Thank you for the presentation. I don't know, maybe I'm making an editorial comment, maybe I'm asking a question. You know, that patient 15 that you were mentioning, or whatever her number is, these are really difficult patients. And, you know, sometimes I wonder if it's really an infection we're looking at, because association doesn't mean causality, and everybody knows that. And at the end of the day, you know, I often wonder if you could even sterilize these patients, whether they would be asymptomatic. And then, so that begs another question is, can you have a patient who has coexisting non-related asymptomatic bacteriuria with overactive bladder as two separate entities? Of course, that would fail Occam's razor and gives you, you know, two independent diagnoses. But just food for thought, because at the end of the day, I don't think we really understand the host response in urinary tract infection, quote unquote. And then when it becomes recurrent, we're spiraling into the world of let's get rid of all the bacteria and they will be perfect. And so I'm not saying that that isn't correct or what we were thinking, but I just want to have a word of caution of association versus causality. Hence, I'm almost like going backwards, saying we don't even understand the acute host response, much less the chronic, because most people who study UTI are on the pathogen side. They will tell you everything about the bacteria, about the microbiome, and we, as clinicians, are treating the host for the most part, and we're sitting here wondering, how do we understand the host response? So sorry for that long question/edit.
That's okay. There's actually, Linda Brubaker presented yesterday that women with recurrent, with stress incontinence actually still have a microbiome as well, and they've got no overactive symptoms. So I think what we're going to actually find is that there are that the bladder is not a sterile environment, and that there are going to be bacteria that are protective against the urgency and frequency symptoms. And I know that there's a particular strain of E. coli that you can infect into the bladder, and that patient will then become asymptomatic. So I think this whole, we're just opening a can of worms here. I think there's a lot of, we don't know enough really. We've got to keep going and finding out more about the urobiome and what's healthy bacteria and what's unhealthy bacteria.
Zimmerman from Dallas, I want to congratulate you. We've done similar work, and we've even gone a little bit further on your slide that you showed the cystitis cystica. We've biopsied these trigones and sequenced those bacteria, and they in fact have multi-drug resistant sites. They're oftentimes different than the one that you would get in the urine, so they may be there silent, but you're going to express the host of other E. coli's you don't know about. So it's very intriguing, and a technical point, if you fulgurate these women, get rid of this chronic cystitis, you'll see the DO goes away. Just a footnote.
Thank you.
So one question for you. In the daily practice, if the patient has a anti-masculine refractory DO or OAB, and the urine culture is negative, the next step would be the botulinum toxin injection. However, in your current method, which patient would you suggest to do the Botox injection, or just jump to find some clinical related bacteria or something?
None of these patients had Botox previously, and I think I would be reluctant to inject Botox in these women that have got proven UTIs, because you're not going to know, have they got another infection, or is it their Detrusor Overactivity that's causing the symptoms? And I don't know if necessarily injecting into these bladders that are infected, I don't know personally whether or not that would be a great idea, but definitely worth possibly trying in some of these women.
Can you clarify, these patients, did they have recurrent Detrusor Overactivity?
Sorry, can you tell us who you are?
Sorry, Bill Gibson, University of Alberta. Did your patients have refractory OAB or recurrent DO, because they're not the same thing?
They all had refractory Detrusor Overactivity, that all had urodynamics that had proven DO.
So they had recurrent urodynamics?
Yes.
Okay, thank you very much. I think it's fascinating that the more we look, the less we know. So go back to Occam's razor. Science truly is agnostic, and increasingly so, I think. So thank you very much.